Well, good night, everyone. It's nice to see all of you tonight. I'm going to present you a case of a 66-year-old male. He's from Nuevo Progreso, San Marcos, so he's kind of close to the hospital. He came with a history of blunt ocular trauma several years ago in the right eye. On his past medical history, he is HIV positive, but he did not bring any CD4 cell counts or viral loads. His vision on that moment is hand motion on the right eye and 20/60 on the left eye. Slit lamp, there was a mature cataract on the right eye with a important phacokinesis and no angle recession. On the left eye was mild cataract. IOP was 11 and 12. B scan, an attached retina, and a clear vitreous cavity. So he was planned for an intracapsular extraction, anterior vitrectomy, and an iris claw lens fixation. This was on February of this year. So surgery was on March of this year. He brought his regular pre-ops. We regularly only ask for two uh, past tests for infectious diseases, which is HIV and VDRL for syphilis. If any of those are negative at the time of presentation, we go ahead with the surgery. If any of those are positive and the patient doesn't have any history of any of these diseases, well, we send them to the respective infectious disease
That's
clinic,
good.
and until they come back with treatment history, then we will do the surgery. So the surgery day, everything went as planned. The only transoperative complication was a persistent bleeding behind the iris, but I was not sure on that moment if it was from the iris claw lens fixation. Uh, it was really hard to pressurize the anterior chamber with the viscoelastic because I already did a vitrectomy. I apply epinephrine and I use a lot of continuous irrigation to try to stop the bleeding on that moment until it seems stopped. Then I finished the surgery. The next post-op visits, vision remained in motion. Uh, there was hyphema and cells in the anterior chamber. There was no visibility of the vitreous cavity. Pressure was normal. We started on topical and oral steroids, semifoliar position, cycloplegics, and a wide spectrum antibiotic. I have to say that he had several visits after post-op one because he never resolved the hyphema and he had two anterior chambers washouts. So we were thinking about an Ox syndrome, and but never he never came with a different presentation. So on April 8th, uh, he was planned for an iris claw lens extraction, believing that the bleeding came from the fixation of the lens. During surgery, again, a persistent bleeding in the anterior chamber, and I was able to see a lot of bleeding in the vitreous cavity that I was not able to reach with the anterior vitrector. So on those days, we had a retina surgeon, and I presented the case to Dr. Jumper, was visiting us with on those days, and we switched the patient to the retina bed and for a complete vitrectomy. On his findings, he found out that the patient had a lot of retinitis patches in the peripheral retina. This picture is not from the patient; it's just a demonstration of how those patches look like. And he gave in the laser around those retinitis patches. But he's even though that he cleaned all of the vitreous hemorrhage, he still told me that maybe the hemorrhage still was coming from the iris or from the superior angle. But he was able to again control that bleeding. But the next days, the patient still had a lot of cells on the anterior chamber, and there was a lot of vitreous opacity, pupillary mydriasis, and endothelial deposits the cornea in the inferior cornea. Again, these are not pictures from the patient, just like an example of how he's still looking like. So Dr. Jumper suggested to me that he might be uh, going through a cytomegalovirus infection, and he might be possible needing treatment for that. But because we didn't have any CD4 counts or viral loads, we weren't able to give him any treatment. So we sent him to his infectious disease clinic that he was the clinic that was treating him. He was with his retroviral treatments, but the next visits were like pretty much the same. The last visit, he was still with these findings. He didn't have any response from his clinic. They needed to make him some tests, but maybe from the place where he visits, they don't do the test there, so maybe they send the test for Guatemala City. So now we are still waiting to give him any treatment. He's still going with this uveitis, if I can say. Patient is not on pain or anything. He just doesn't see anything yet. So this is like not we still haven't finished on this case, actually, because we are still missing for the response on the treatment for the possible cytomegalovirus. But I wanted to bring this case because uh, at least our center doesn't have like maybe we are not paying that much attention to the HIV patients. So I brought here some special considerations to think when all of the doctors that are on the at the center ask for the patients. So some special considerations: the chances of getting infected by a needle prick injury, which is by far the most common form of exposure to surgeon, is 0.3%. Mucous membrane splash to the eye or oronasal is about 0.09%. So we are pretty safe on this. But we have to ask for more things to our patients. So for every HIV patient from now on, we are going to ask for a CD4 count, thinking that if they bring a result from 200 cells or less, we have to think that these are more associated with a higher mortality rate for the patients, and we have to think for more infectious diseases inside of the eye or the body. And the viral loads, if they are over 75,000 RNA copies, so still the higher mortality rate. Also standard laboratory tests, which are useful in determining the prognosis in AIDS patients. So we are not going to ask just for the test if it is positive or negative. And if it's positive, we are going to ask from now on the CD4 counts and the viral loads to know if the patient is in risk of presenting anything else inside of the eye, and to be aware if the patient needs any other treatment beside of the cataract surgery, to not having for not having again this type of surprises, and for not waiting that long for the patient to have a treatment. So this is something to come around. So which other precautions for the surgeon? In 1987, the CDC issued guidelines for minimizing the risk of HIV transmission in health and care setting, called universal precautions, which these guidelines are now, well, they said that they have to be used for any type of patient, not only an HIV positive patient, which is hand washing before and after all medical procedures, safe handling and immediate safe disposal of sharps, safe decontamination of instruments, the use of protective barriers whenever indicated to prevent direct contact with blood and body fluids, such as gloves, masks, goggles, aprons, and boots, and a health work care person who has a cut or abrasion should cover the wound before providing any care, and safe disposal of contaminated waste. With type of comorbid conditions that an ophthalmologist has to rule out in an HIV patients before doing any surgery on them. Nexal manifestations like herpes zoster, Kaposi sarcoma, molluscum contagiosum, trichomegaly, some anterior segment manifestations like conjunctival microvasculopathy, keratoconjunctivitis Zika, infectious keratitis for a varicella zoster, herpes simplex, fungal, microsporidia, hydrocyclitis, posterior segment manifestation, and HIV retinopathy, related retinochoroiditis, cytomegalovirus retinitis, acute retinal necrosis, which is hard in cases like this patient because he had a very mature cataract from the beginning, so we were not able to see any of the posterior segment until he had the retina surgery. But we still have to rule out all of these pathologies before doing anything. So to send him or to be aware if the patient is receiving the right treatment. The preoperative management should focus on achieving the acquiescent eye for patients with a history of uveitis, which our patient may have any uveitis before consulting because of the blunt trauma, and know that he hasn't had the uveitis, an active uveitis for an extended period before surgery, because postoperative outcomes may not be as favorable as those of patients without a prior uveitis, and the uveitis may attenuate visual gains, demonstrating less improvement in the visual acuity. So again, what to do in case of an exposure, just for a reminder, what to do, remove, if we, in case of a cricket injury, remove gloves, if appropriate, wash the exposed side thoroughly with running water or irrigate with water or saline in eyes or mouth has been exposed. Wash the skin with soap and water. What not to do not panic, do not put the pricked finger in the mouth, do not squeeze the wound to bleed it, do not use bleach, chlorine, alcohol, bethadine, iodine, or any other antiseptic detergents on the wound. This is an article from the India Journal of Ophthalmology, released on March of 2019. On this article, they interview around 400 ophthalmologists from India. In India, there are around, in the article said that there are around 16,000 ophthalmologists. So they admit that they had like a pretty good sample of ophthalmologists. They interview them through WhatsApp to ask them some questions about how they manage their patients during for a cataract surgery plan, for planning a cataract surgery. So a lot of them were comprehensive, or they weren't doing any cataract surgery, so they rule all of the surgeons that they didn't do any surgery at all. But the ones that do the cataract did cataract surgery, nearly 7% of them, of the surgeons use double gloves when operating cataract in seropositive patients, effectively against secondary percutaneous perforations. Other strategies of using, in case of phaco surgery, using a separate handpins and in phacoprop tips, or to operate seropositive patients, to separate the phacoprops from the seronegative patients. Also, as these type of viruses and the hepatitis C or B viruses are, well, they tend to be eliminated only with heat or some disinfectants. So the surgical instruments that are in contact with tissue or body cavities or bloodstream, that can be heat sterilized, and the other ones that are, if instruments are heat sensitive, they can be disinfected with high level disinfectants at 2% glutaraldehyde or 7.5 hydrogen peroxide. So I brought all of these precautions just for a reminder of how to. Oh, the presentation closed. You are no longer able to see my presentation right now, right?
No, we are.
Yeah.
We can see
I
it.
can see it. I can see it. Well, this is what I brought tonight. So I wanted to ask you if any of you do anything different for these seropositive patients, or if you are agree with the idea of us to ask for every seropositive patient to ask for the CD4 counts and viral loads, and have like the preoperative evaluation from their own infectious disease clinic. So this is what I'm bringing on tonight for your opinion.
I'll make one comment, Claudia. First of all, I'm sorry I missed the first 8 minutes. I think I got the gist of what you're saying. Just for the group, I want people to understand that in Nuevo Progreso, there 2 blocks away, there's a government health institute, CAP, and I was there in May 2023, and at that point, they were providing multi-drug therapy for 29 HIV positive patients in Nuevo Progreso, which I was really, really surprised to find that out. I had no idea that many HIV patients would be in that region and would be provided care from the government. So that was one thing. And then my second comment was that I have seen a few HIV patients, as you've mentioned, come in. But my kind of more perspective comment is that, when I trained in San Francisco in the mid 90s, we would see, HIV patients every day, San Francisco, with who were dying, and they all had CMV retinitis, and they all had, they had multiple diagnoses, and so the surgical approach when surgeries needed to be done, and this is before multi-drug therapy, so they all had elevated HIV loads, and they had no T cells in their bodies. So those patients were very sick. None of the surgeons I worked with would double glove at that point. The feeling was that was more risky than just doing what you normally do, because you would lose some of the feeling. And then maybe the thought experiment that goes along with that comment is just to ask yourself, how would you operate differently if every patient you knew had some type of an infection that would be serious to you, and how would that change your behavior as a surgeon or as a practitioner? So there's just a couple comments that don't really call for any specific response, but I'll turn it back to you, Claudia, to direct a discussion about your question, but I thought those were pertinent.
Claudia, I'm curious about, I often marvel at how things happen, that patient happened to come in during the week that Mike Jumper was there, who is a retina specialist in San Francisco and has probably seen more CMV retinitis than this whole panel put together. Did he have any ideas or suggestions about your questions?
Yes.
Did you have a good discussion with him? Because he's a wealth of knowledge in this topic.
Yeah, well, the first thing that he asked me if I knew that he had if I knew the CD4 count cells or the viral loads, and I was like, no, we usually don't ask for any of those to the patients that we know that they are HIV positive. We only ask them if they are on their treatment, and if they are good, that's fine. But we don't search for anything else. But I think that's something that we are going to change from now on, in order to not, because it is like really getting slow for this patient to have the response from his infectious disease clinic, because he said that he goes to Coatepeque and they haven't given any treatment, and in the meantime he is still with the inflammation inside of the eye going on, and but we can't do anything. He said like, you should start on galaciclovir, but I mean, we don't know how to treat him because we don't know anything else, right? The CD4 counts and the viral loads. So we are like still waiting for him to get the response on that. And we sent a note. We sent a note for the infectious disease clinic, uh, describing that he had suspicious of cytomegalovirus inside of the eye, so they should start treatment for that, because he needed something. But still, he doesn't have any response yet. So that's.
Can I make a comment? He's not on any treatment for the HIV.
He's supposedly to have. He's on his retroviral treatment, but not like on galaciclovir or in any other antiviral treatment.
Because people on heart treatment for HIV would be very unusual for them to develop CMV retinitis.
Right. That's why we send him the note for him.
I just wanted to comment on this because, like Andy, back in the day, we saw so many patients with full-blown eye AIDS. Probably a lot of older physicians have seen this, but now essentially we never see it because of heart therapy. My thought is it would be useful getting the CD4 because it'd be nice to know, hey, this patient is getting the totally available treatment, so their disease is essentially squelched. I've seen only one case of CMV retinitis in the last 5 years, and that was a drug addict who wasn't taking heart therapy. Yeah. But seeing countless, so AIDS essentially doesn't need to exist anymore, is what it comes down to, at some level. So I think it's rational that, like Mike was saying, like, hey, let's find out what their CD4 count is and make sure they're fully treated. If not, let's fully treat them. But we have an update on this patient that Melanie can give.
So yeah, actually he came in today to the clinic, and he was the last patient to be seen today because, I mean, he wasn't scheduled for today. And he came in because he started with a lot of pain yesterday. And when I saw him, so my suspicion was that he was a person with an endophthalmitis. And then I asked Dr. Paulson, both Dr. Paulson's got opinion on him, and they agreed with me. He was like you couldn't, I mean, there was like a lot of corneal edema, a lot of injection. IOP was normal, he was in pain, and you couldn't see anything through that like super dense vitreous. Like we couldn't see anything at all. So we were thinking what would be his best shot. I mean, we all agreed that we would all like for him to get a vitrectomy as ASAP. But I mean, it's not going to be possible for him to travel like all the way to Guatemala to get a vitrectomy. And since this is like a very time sensitive condition, then we decided to take him to the OR, and we did like the core vitrectomy through arch clean a lot of that like very turbid vitreous, and then we did intravitreous antibiotics. So we'll see him tomorrow, and we'll let you know what we see. But yeah. He came in today, and it's funny that you're presenting him today.
With the history, though, that you have, that we understand now, we'll try to get some ganciclovir so we can inject that.
He didn't came with any note response of the clinic.
Oh.
Yeah, we have no information from the ID clinic either, still.
Yeah, he was supposed to come on the 21. I don't know you. No, thank you for the update. So any other comments? You all agree about us asking for all of the patients for the CD4 count and the viral loads and using the double gloves and separate the instruments that we use on them of the seronegative patients?
Yeah. Okay. And one other thing I would add on that, Claudia, just a matter of, I mean, answer my own question about it. What would you do differently? You know, one thing I would say, like, I'm not a big fan of the double glove, but I am a really insistent on all my cases when I have a sharp, and every time I put a blade back on the table, first of all, I always point the blade towards myself and not, I don't point the blade out towards the staff. So if that's the blade, when I put it back, I'm always putting it back so that I'm guarding it. And then I always say, and I think this is, in terms of best practices, I would always say, sharp on the table, or I don't know how you say in Spanish, ya retorno la aguja, or ya retorno el cuchillo. Is that what a knife is? But somehow developing the practice of always, you are responsible for your assistants and your technicians. Um, and, so if you have a table with sharps on it, and you do, having them, announcing when you're putting them in. If sometimes you can even clean up I mean, I don't think you need to clean up. If I were operating on an HIV patient, um, in Guatemala, I would be extra deliberate about returning the sharps, but I might even, in those cases, be the one that says, let me take care of these and dispose of them properly. But there's a balance between added precautions that interfere with your rhythm, and smart precautions that in those cases are maybe especially needed. So it makes a lot. Now, checking the CD4 count on every HIV patient. I mean, someone should be doing that. I don't know. It has to be you, but that if it's a new patient, then they should be referred to the medicine, to the internal medicine, where they should get followed up for their disease, rather than have you responsible for that. Did I misunderstand what you wanted to do with that?
No, just like as I told you, to rule we all from now on like rule out any other disease inside of the eye. Like we weren't able to see anything inside of his eye because of the cataract, and after that we weren't able because of the blood and the vitreous opacity that remained even after he already got a complete vitrectomy done. So
He
be
didn't.
aware
He never had any
of
findings in the other eye.
the other eye is remarkable.
It's interesting.
He just need cataract surgery on that eye like so far, but we have to like solve first the first eye.
Yeah. And do you all do, so you were talking about HIV patients, do you have any different precautions or procedures with hepatitis patients,
Well,
with
even
hep
if
C
we
or hep B?
know if any of we don't usually ask them for HIV testing. We
Right.
only ask for syphilis and HIV.
Mm-hmm.
I don't know if we should ask for it. I don't know if you ask for hepatitis B or C for your patients.
I mean, I think it's good to know just as part of their general medical history.
Right.
And I
So
agree, we don't do anything differently in the OR, but we're aware of their status, but we don't do anything differently. So
right.
it, I don't know that it does anything other than kind of heighten everyone's anxiety, but we do the same thing.
Hey, you tell the technicians, this is
Yeah.
Mr. So and so. It wants he's HIV positive, or
Right.
yeah. I did have a patient. Well, we did have an event where a technician was poked with a Utrata instrument.
Lo que tengo con mi celular, güey.
And the Utrata instrument, it's a longer story, but had been contaminated by a prior patient who was HIV positive. Just just it's a longer story than I want to explain right now, but it gets you into the literature of how common um, con transmission of HIV through a glove. It's just, I mean, it's exceedingly rare. You said point, I think you noted 0.1% is what you had, or it's the idea is that the glove kind of squeegees off the needle, and then the needle is probably doesn't have any blood droplets on it anyway. So there's a lot of reasons that make it so unusual to transmit. Um, and I think transmission of HIV with someone whose T cell or whose viral load is zero, like I don't even know if that's been documented. Anybody else know? I don't. It's just they're not cured, but that's why HIV patients who are positive, I mean, that's why the incidence of HIV transmission is down, because their sexual partners don't have a viral load. So
I have a question. Do you know if there have been any incidents of poking their fingers or, getting stabbed by the OR staff? Have you heard anything?
What?
and are you talking about in Nuevo Progreso?
Yes.
Oh,
At least on the days that I have been there, it's not that usual. They are really precautious of with the needles, actually.
Yeah.
Not that usual.
I'm just wondering, I mean, to answer your question, should we be doing something different? And, I think all precautions should be taken, to protect the surgeon and the staff. But I think that, just as long as we know that this patient is HIV, just be extra careful, but don't super heighten their anxiety, I think. Like Jeff said, sometimes if you mention something like that, they're extra anxious and then might poke themselves. But I just think that if we follow through the correct protocol, getting rid of the sharps, and we can say, cuidado, esto tiene filo. That's the words, I guess. Andy, cuidado, esto tiene filo.
this is sharp.
Yeah, esto tiene filo.
Esto tiene filo.
Yeah.
Jorge, if there was an accidental, significant needle stick injury, would you send the patient to get tested and you didn't know anything about their history, or just a regular patient? Would you send them for HIV, Hep B, Hep C?
I think so, yeah.
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 I would send both.
Yeah.
But yeah.
Makes
And
sense.
I once got pricked, and we didn't know if he was being tested by HIV, but I was doing my intern rotation, and it turned out he had some kind of tuberculosis. So I was on tuberculosis meds for about a month,
Oh, wow.
and I'm still healthy. So
It was really common on med school that we all heard that a lot of our friends poked their fingers with HIV patients or tuberculosis patients, because we were asked to take the blood samples or los gases arteriales. How do you say that?
Material gases.
Yeah. So I think that all of the any med student has a history of a poke. But in ophthalmology, it's like really weird to poke our fingers.
I worked in the ER once and was suturing somebody and squirted. I can't remember how I ended up squirting like a lidocaine, and or I can't remember the situation. Somehow a drop of the patient's blood got in my eye, and my eye totally got red and irritated and inflamed. I was just surprised what a reaction, because we do these serum tears now, right? They're supposed to be really good, but it is an inflamed area. It's it just yeah. I think universal precautions is smart. Just and then as we bring these, we do have a lot of people going through there, right? You have a lot of residents and you have new staff, and it's tight. So maybe just a discussion with the staff, bring everybody together and just talk about, this is just want to remind everybody, si tiene filo, how we dispose of things. Don't recap needles. I mean,
Yeah.
that's an easy thing to just stop doing that. A lot of times I'll see nurses get drug from a bottle, and one person's holding the bottle and the other person's holding the needle, and they're trying to. It's like docking a space shuttle,
Mhm.
um, and just identifying all those areas where you are putting either yourself or someone else at risk. I think that's worth a discussion, just so they think about it, because those needle sticks are, um, yeah, they're definitely avoidable.
Sure.
Thank you, everyone. Thanks.
Okay, bye.
Good night.
Bye.